Hello ladies and gentlemen, my name is Cohen-Gadol. I'm a neurosurgeon. I have been involved in the management of trigeminal neuralgia surgically for the past 20 years, and I like to share my experience and information that patients would benefit from for their journey as they try to receive treatment for this terrible pain. I like to start by saying that trigeminal neuralgia is truly one of the worst pains humans have been afflicted with, and having an opportunity to relieve the pain for the patient is truly an honor and one of the most rewarding experiences in medicine and neurosurgery specifically. So the definition of trigeminal is very important because this pain is often confused with atypical facial pain. So I want to really emphasize this point here. Trigeminal neuralgia is a chronic condition which causes shock-like pain in the face. Again, not a constant burning pain. It's an electrical shock-like pain in the face, either unilateral and extremely rarely bilateral. It's typically in the jaw or the cheek. The pain is set off by triggers related to facial pressure or motion. In other words, talking, chewing, wind hitting your face, shaving, or other related activities. The pain can usually last a few seconds to minutes and occurs episodically. So again, the diagnosis is important. It's electric. It has a location that's specific. It's not constant. There's specific movements and actions that make it worse. It is not burning. It's not constant. It's not in unusual locations behind the ear. Those pains are atypical facial pain and should be carefully dissected away. We don't want to treat certain pain syndromes that are not trigeminal neuralgia with surgery because the outcomes will not be good. So typically trigeminal neuralgia can occur at any age, but commonly they are among adults over 50 years of age. And women are unfortunately afflicted more frequently. It's important to know that this kind of pain in a very young individuals is unusual, and therefore typical trigeminal neuralgia in a young person has to be carefully inspected or investigated before surgical offering has been discussed. What are the most common symptoms? One more time: episodic, intense, shock-like pain in the face, in a jaw or a cheek. It can be around the eye as well. The attacks can last seconds to minutes. They can be in rapid succession and periodically over days, weeks, or months, or they can be periods when the patient is pain-free. They can be brought about by cutaneous stimuli, and the less common symptoms are pain around the eye, lips, or teeth, or gums. What are the stimuli that lead to the generation of the pain? Eating, drinking, shaving, talking, smiling, brushing your teeth, or applying makeup. How do we do the diagnosis? The most important factor in diagnosis is the patient's symptoms, not the imaging. Why is that so important? Because an MRI performed can show vessel around the nerve that may not be the cause of symptoms. In other words, people without a facial pain normally have vessels around the nerve that goes to your face. We do the MRI for the diagnosis because if the patient has the typical symptoms and has a vessel compressive the nerve to the face, those are two features that make us feel comfortable with the surgical treatment. But again, imaging is not a diagnosis for this pain syndrome. Initially, before we consider surgery after the patient has been diagnosed with trigeminal neuralgia, and again, typical trigeminal neuralgia, there are many treatments. Medication is number one. We have to try medication at least for 6 months. Medication is most often effective for those pain syndromes that also respond well to surgery. So if your trigeminal neuralgia is not responding well to medication, there could be questions raised if the pain can be effectively treated with surgery. So if your pain initially responds well to medication and then it doesn't later, that's actually a good sign that surgery can be effective. Regarding surgical treatments, the first modality is microvascular decompression surgery, where the surgeon puts you to sleep under anesthesia, creates an incision behind your ear, removes a piece of bone, dissects the artery against the nerve, and places a patch between the artery and the nerve. That's highly effective and very durable. There are also other options called ablative treatments, such as percutaneous stereotactic rhizotomy that involves glycerol injection, balloon compression, and radiofrequency rhizotomy, where a needle is placed when you sleep during a short procedure and the nerve is injured so it does not generate pain. Also, another option for treatment, which is least invasive, is stereotactic radiosurgery. We're going to talk more about that in a moment. Let's talk about medication. They're the common initial treatment. Their effectiveness may diminish over time. We usually use anticonvulsant or anti-epileptic medication such as Tegretol or Neurontin to treat your pain. We may use muscle relaxants as well, but usually less often, and tricyclic antidepressant may be used as well. So when we talk about microvascular decompression surgery, the surgeon using a craniotomy, which means a small opening in the head, in the back, in the skull, locates the blood vessel compressing the nerve, as you can see in the image. A piece of Teflon or a plastic implant is placed between the nerve and the offending blood vessel to minimize the contact between the two. And this, in 80% of patients, halts the pain and is quite effective. And risk of recurrence is about less than 10% in 5 years. So very effective pain control and very enduring. Other ablative treatments like the rhizotomies I discussed, they typically have a higher rate of recurrence, about 30 to 50% in 5 years. However, they can be repeated, and in older individuals who may have high risk of staying under anesthesia for a long period of time, it can be quite effective. Also, for multiple sclerosis, where a vessel is not cause of the pain, the ablative procedures can be quite effective. So possible complications related to microvascular decompression include excessive numbness in the face that can be irritating, hearing loss, facial weakness, numbness, double vision, or other related complication. In cases where the surgeon does not find an artery compressing the vessel during surgery of microvascular decompression, that can happen in about 10 or 20% of cases, the surgeon may injure the nerve by cutting a part of it only or gently massaging it, and that may cause some numbness in the face, but your pain will go away. We don't want to cause too much numbness from the surgery, because that by itself can cause significant pain syndrome later. So overall, the pain can be cured for a long period of time with surgery or other modalities. So for people who are unfortunately suffering from this terrible pain, good treatment exists. But please note, not every facial pain syndrome is amenable to surgery. This is the most difficult factor in treatment of the patient suffering from this terrible disease. There's also a chance that pain can come back. And at that time, obviously, we can try other treatment modalities besides microvascular decompression surgery, such as needle procedures or radiosurgery. So overall, trigeminal neuralgia surgery is extremely effective. It is very gratifying for me as a surgeon to be involved in surgical treatment of thousands of patients for the past 20 years. And if you have been offered a surgical treatment and your pain is very typical, I'm more than happy to be involved in the surgical treatment for your pain as well. And I wish the best for your journey in your care. Thank you.